Hello, I'm Viola Holmes, the Associate Director of Nutrition at the ADA, a registered dietitian and certified diabetes care and education specialist. Thank you for joining us for this conversation about the curriculum, What Can I Eat? Healthy Choices for American Indian and Alaska Natives with Type 2 Diabetes curriculum. At the end of the interview, I'll share with you how you can access the curriculum at no cost. But first, I'm happy and I'm excited to have with me here Dr. Sarah Stutz, who's a registered dietitian and certified diabetes care and education specialist. Sarah is assistant research professor at the University of Colorado Anschutz Medical Campus. Sarah, thank you so much for joining me for this conversation about a program that I know is near and dear to you. The What Can I Eat? Choices for American Indian and Alaska Natives with Type 2 Diabetes curriculum. I would love for you to begin by sharing with me a bit more about yourself and the type of research that you focus on.
Yeah, sure. Well, thank you so much for inviting me to be here today, Viola. I'm honored to be able to participate with this and talk about what can I eat, and of course spend time with you. So as you mentioned, I'm here at the University of Colorado. I'm in the School of Public Health and in the Centers for American Indian and Alaska Native Health, which is based in Aurora, Colorado, but essentially is Denver. Like you said, I'm an RDN and CDCES, and I worked in direct patient care for many years before going back to graduate school for my doctorate and postdoctorate training. That training all focused on the development, implementation, evaluation of food and nutrition programs for people who experience limited income, food insecurity, and nutrition-related chronic disease, such as diabetes. I do want to take just a moment to acknowledge that I was not the PI or the principal investigator on these studies. That was my mentor, Dr. Kelly Moore. So her leadership in this project and mentorship, it was invaluable, as you know, from working with Dr. Moore. I also want to note and thank the funders for this work, which was, of course, the ADA and also the Shakopee Mdewakanton Sioux community of Minnesota. And also just need to acknowledge the whole What Can I Eat study team. Though I get to be here with you today and Kelly was the PI, we both certainly worked with many people involved in the development, the evaluation, all of the clinic-based collaborators, and mostly the participants who stuck with us all through COVID to pilot the intervention and see how What Can I Eat went at different clinic settings.
Thank you. Yeah, this has been such an awesome and an impactful partnership with all of the partners that you mentioned. So we're excited. But the original What Can I Eat curriculum is a community-based, 5-lesson, nutrition-focused support program for adults with type 2 diabetes, their family members, and their caregivers. So that was developed by ADA. So how did the idea to adapt this particular program for American Indians and Alaska Natives come to be?
Well, so the actual kind of idea for this was before my time, but from what I understand, the idea for this curriculum was adapted by a partnership between American Diabetes Association and, again, the Shakopee Mdewakanton Sioux community of Minnesota. That community engaged in an initiative, which I think started in 2014 or 2015, called Seeds of Native Health, which was a campaign to improve Native American nutrition nationwide. And they engaged in several innovative and groundbreaking initiatives kind of throughout that effort. The community must have kind of determined nutrition or diabetes or both was a key priority area. But then, of course, by the time Dr. Moore and I were invited to adapt the curriculum, the idea had already been established. So I think that's the origin story. But I do think it's fabulous that, at least in part, the idea and the initiative was community driven through the generous insight and work of the Shakopee Mdewakanton Sioux community in Minnesota.
I agree, and thank you for that history on the development. So to identify the facilitators and barriers to healthy eating in these communities, you held focus groups and you conducted interviews with 4 different groups or types of people. Will you share with us who the different groups were and maybe provide an example of a discussion question or two that you used?
Yeah, so we had the privilege, and this was before COVID, of engaging community to identify the diabetes, nutrition, education needs of American Indian Alaska Native communities. And we did so by speaking with American Indian Alaska Natives who had existing type 2 diabetes and their adult family members. So it could be a spouse or an adult child at 4 geographically distinct sites across the United States. And then at each of those 4 sites, we also talked to dietitians and people who had expertise in traditional foodways. And then we also got to talk to nationally based experts in American Indian Alaska Native diabetes health, health equity, food, nutrition, tribal leaders, and tribal food sovereignty experts. However, this needs assessment wasn't just to identify facilitators and barriers. Rather, it was really to just learn from community about diabetes, nutrition, and health from their perspective and from their value base. So our focus group discussions and interview questions focused on stories, Native values, and strengths of these communities. For example, we asked what healthy means to the participant so that we could really understand, what kind of goals and values for health might be. And we also asked how they like to learn when they had a specific question about their diabetes or health, so we can build on the places that they're already comfortable learning in adapting this curriculum.
Very comprehensive and thorough, it sounds like. Thank you. So there's a statement that was made by one of your group participants that they recommended tying diabetes, nutrition education to the way their ancestors worked, played, and ate. I thought that was very lovely and well said. So are there any other things that you found from these interviews that you would like to share with us?
Yeah, I'm glad you pointed that out, Viola. I really love that too. And just recently, I was interviewing an Alaskan Native physician scientist, and he mentioned the phrase culture as medicine. And I love that. I had never heard of that. I had always, of course, heard as food as medicine, as many of us in the nutrition world have, but I'd never heard of this culture as medicine. So really, the solutions to healthy eating lie within these communities. Traditional American Indian Alaska Native foods and food systems were all inherently diabetes preventative. And so diabetes in American Indian Alaska Native communities is really a direct result of generations of colonial violence, including forced removal, forced poverty, the imposition of a Western-based food system that included high fats and high sugary foods. And the people know this. And so they want to have opportunities to learn from one another, to learn from their elders about traditional foods and foodways. I think some of the ways we think of nutrition education needs to be a little more centered on Indigenous values. For example, it might not be appropriate to only educate one person in the family with diabetes, or even that person plus their spouse, as the value on the collective might be thinking about the whole family or even community-based health rather than just one individual. I think that health also might not just be focused on physical health. And so rather thinking about the balance between all components of holistic health, including physical, mental, emotional, and spiritual, and so forth. And there's a lot of value in engaging cultural teachings around food and nutrition, which can often address many of these aspects of health. However, I need to note that the people who lead these education efforts really ought to be Native themselves, or at least very familiar with the community, or bring in guest speakers or guest educators for those appropriate parts of the curriculum where traditional foods, traditional foodways, and culture is interwoven into the curriculum.
Thank you, and thanks for sharing the culture as medicine. Because it really is about more than food, right? It's about the whole person. Yeah. So Sarah, did you find any unique barriers to healthy eating in these populations that you really needed to make sure this curriculum addressed?
Yeah, so I think it's important, of course, that when we approach any health disparities, including diabetes disparities, we come first from a strength or an assets-based approach, right? And that we're also educated on the historical context of any given community's disparities. When we think about barriers, sure, there are things that make it hard to eat healthy. Everybody has these, some more than others. We can think about things like financial drivers, such as poverty, and logistic or access drivers, such as poverty again, and the implications of colonization and present-day racism that impedes many American Indian Alaska Native people from achieving healthy diets. These are the determinants of health that expand beyond individual level capacity building. However, we can also more appropriately think about the strengths of these communities, that again, those traditional foods and traditional food ways are inherently diabetes preventative. Physical activities such as youth sports are really common and popular among many Native communities. There's intergenerational family support and strengths in relationships and relationality, beyond just with people, but also with the land and the environment. There's values, again, that are connected people to their land, and thinking about the relationship between environmental health and human health. So yes, of course, there's barriers, and these look different for American Indian Alaska Natives who live in urban areas versus reservations versus rural areas. But again, I think many of the barriers that these communities face are related to trauma and the need to center cultural healing as a focal point to supporting holistic wellness, including diabetes wellness.
Yeah. So you mentioned traditional foods, and the curriculum has a list of traditional foods. How do you suggest that programs or educators further adapt that list based on state or regional traditional food preferences?
Yeah, that's a great question, Viola. And I think we often get lost when we adapt something, right, for American Indians, Alaska Natives. We have to remember that, of course, there's diversity, right, across the country among these communities. And so this is going to be really specific and regional. I mean, what is accessible? What is traditional? Each educator would need to tailor this. And I think probably with the guidance of elders in the community and community members as to what that means for any given community. It might not be a food, rather a food acquisition technique, right? Maybe gardening or berry picking or something like this, fishing, hunting, drying, canning, foraging for mushrooms. There's all these things of food acquisition techniques or the traditional food ways that also can be integrated into these kind of programs. In any given setting, just querying the elders of that community to understand what traditional foods are pre-contact is also really important. And then working with also community to understand which of these traditional foods are accessible and available. So because of removal from native lands, there are some traditional foods that are not accessible. And so we certainly wouldn't want to, promote a food that's just not accessible and leave it at that. We want to be able to give people the tools to actualize the inclusion of traditional foods into their meals, and whether it's daily, weekly, or even just monthly. I think for a non-native educator like myself, the first thing that I would do is just listen, right? So often as nutrition educators, we're used to doing the talking, we're used to holding this knowledge and wisdom about nutrition and diabetes, but of course, there's motivational interviewing as approach to individual nutrition counseling, but I think listening without an agenda, letting the community teach you about what traditional foods and traditional food ways means to them is key and most important here.
And I'm sure that took some time, right, to develop that relationship and being able to do that.
Yeah.
So for providers, those educators who work in diabetes self-management and education programs, how would you recommend that they incorporate this program into the curriculum that they already have for DSMES?
Yeah, so this is a nutrition-specific curriculum, so it would need to be paired with programs and education resources that include other aspects of diabetes self-management and care, right? So foot care, self-monitoring blood glucose, medication management, that is not included in this curriculum. And because of that, one thing that I will share is that we scripted this curriculum to the word with say, do, act, ask, and then possible answers to those questions so that it could be taught by non-registered dietitian nutritionists. We have to remember that in Indian country, there's not a lot of registered dietitian nutritionists, and we would be exacerbating issues of equity and inequity if we only had dietitians that were able to teach this curriculum. So it's scripted with that intention. Because during our needs assessment as well, we learned from the communities that who delivers the program is really important, that folks really wanted, if that person wasn't an RDN that person needs to be really familiar with the community, trusted by the community, native him or her themselves if possible. And again, because there's not a lot of native registered dietitian nutritionists that serve Indian country, we certainly want to make sure that those audiences are still able to be served by the curriculum. So I can envision, a co-teaching scenario would be really great in spaces where perhaps there is a registered dietitian, nutritionist, and maybe this person isn't really familiar with the community or not a community member themselves, could bring in kind of guest speakers, if you will, for some of the topics about traditional foods and foodways. And that could be an elder in the community, or it could be someone who's just very interested in food and nutrition in their community. So we have a couple kind of placeholders in the curriculum where this would be a good place to bring in, an expert in your community on this topic, and have some co-teaching there as well.
Exciting. Again, lots of space to be flexible to meet the needs of the community. That's great. So Sarah, is there any other significant findings based on the cultural adaptations that you would like to share with us at this point? Anything else about the program that kind of you want to make sure you hit home here?
Yeah, so, we did get to pilot the curriculum at 5 different sites across the United States, and that was during COVID. So we found some kind of key salient themes that emerged after participants had completed the curriculum. Again, during the COVID pandemic, folks were pretty isolated. And so having some kind of these were Zoom-based classes. And so the camaraderie, the peer-to-peer learning, and then just the ability to talk to one another was really, really popular. And we don't know for sure if that's because people were just so isolated or because they really did enjoy, just talking about diabetes and nutrition with peers. But we did learn that folks really did like the unstructured time that we had in the classes. We kind of had some spaces where there was a card with a kind of a question that pairs would ask each other, or a group of 3 would ask each other, and they talk about food and nutrition and barriers and challenges and their own personal workarounds for some of the things that made eating healthy hard. We also learned from folks that they would like to keep some kind of hybrid component, which maybe surprised us. We were thinking, once the pandemic was over, this would just be a completely in-person event. But some folks really did find value in not having to travel, not having to find childcare, and so forth, as lots of us learned with our program delivery throughout the pandemic. But they really did think, it'd be nice to have some food tasting opportunities, some time to share in-person space. So we're really excited because now in coming up in the fall of this year of 2023, we're going to test the curriculum in person at a new clinic and see how the classes go in live time. But just to close here, just super grateful for the ADA for their support in this effort, and thankful for the Shakopee Mdewakanton Sioux community, and then also the leadership from Kelly Moore, and really all the support from our sites that we really had to pivot during COVID, as many people did, with their research and their education, and all 5 of our sites stuck with us throughout the whole pivot of COVID. So that was really showed that we had some good relationships, as you mentioned, with our communities. So thank you so much for having me today, Viola.
Thank you. And this is so exciting. I just love facilitating groups and group education, the whole process, because you really see, as you described, how it works, the groups jive. And so we're looking forward to hearing more from you about, other projects and things that you're working on. So thank you so much for your work on this project, for seeing it through to publication, and now the curriculum's availability to healthcare organizations that serve American Indian and Alaska Natives at no cost. And as Sarah already mentioned, this opportunity is made possible because of our partnerships with Genentech, as well as the Shakopee Mdewakanton Sioux community of Minnesota. So a big thank you to everyone. If you're interested in the curriculum, please send an email to WCIE, that's abbreviated for What Can I Eat, WCIE Native American @diabetes.org, for access to the materials, which includes the facilitator's guide, the participant guide, as well as the share questions that Sarah described during this time. And you'll just have to complete a brief agreement so that we know you have it. And if there are updates, we can share those updates with you. So thank you again, Sarah, and everyone who's been involved with this. And we look forward to getting the curriculum